Everyone. Welcome to all that are here in the auditorium with us and also to those online. I am extremely excited to be the moderator today for the session from Dr. Kelly Cobey, introducing the Metaresearch and Open Science program. So it's my pleasure to welcome Dr. Cobey. She's a new scientist here at the University of Ottawa Heart Institute, where she leads the Metaresearch and Open Science program. She's also an adjunct professor in the School of Epidemiology and Public Health at the University of Ottawa. Kelly completed her PhD in social psychology at the University of, I'm not going to say this right, Groningen. Good. University of Groningen in the Netherlands. And following that, worked as a lecturer in the School of Psychology at the University of Stirling in Scotland. She subsequently worked as an investigator and as the institution's publications officer at the Ottawa Hospital Research Institute, where she provided internal and external consulting on publication best practices. She holds several national and international leadership positions in terms of the meta-research community, and since 2015 has been a member of the Equator Canada, which provides educational outreach and support for the use of reporting guidelines that we're all familiar with. She's incoming co-chair of the DORA Declaration on Research Assessment Initiative, which aims to drive the use of more responsible metrics to evaluate research and researchers. And then her capacity as a consultant, Dr. Cobey has provided educational outreach and strategic planning to a number of organizations, including PHAC, Health Canada, Canadian Standards Association, and CADITH. She was recognized by the University of Ottawa as a co-recipient of the Open Scholarship Award in 2022 by CHR with the Research Excellence Award. And since becoming a scientist here at the Heart Institute, has quickly become one of our best collaborators. And so it's very exciting today to have her introduction to her Meta-Research and Open Science program, which is going to be a really integral part of the Data Science Center here at the Heart Institute. So I welcome Dr. Kelly Cobey.
Good morning, everyone. Thank you so much for your time today. I'm really excited to be here with you and to share a little bit more about the Meta-Research and Open Science program. Okay, just to begin with a land acknowledgement, acknowledging and paying our respects to the unceded Algonquin-Anishinaabe territory and the Algonquin-Anishinaabe Nation. No conflicts of interest with respect to the chat today. I will mention Equator Canada, DORA, the Open Science Framework, and FAIR Data, or aspects of work I'm doing related to them, but they're all sort of unpaid roles that I'm engaged in. Of the talk today, my aim is sort of twofold. So I wanted to give you a sense of my current research focus in the Meta-Research and Open Science program, and actually provide you with a bit of perspective on the methods that I use, with a view to hopefully make you aware of what I'm doing, but also build potential bridges and collaborations for folks who are interested in tapping into some of the methodological expertise that I have, or doing meta-research and open science within their own program. I wanted to provide a little bit of context. So you see baby Thea up there. So I'm coming up on 2 years at the Heart Institute. In November, it will be 2 years, but 13 of those months I was off on maternity leave with Thea. So it's really been 6 months since I've been back and really sort of building up the program that I'm starting here, the Meta-Research and Open Science program. Okay, so first things first, what is meta-research and what is open science? Meta-research is basically using the scientific method to study science itself. You can think of it as research about research. So meta-research looks at the application of the scientific method and whether it's being applied appropriately. So we're looking to see basically, are there gaps in what we set out to do and what we actually do? And if so, can we remedy those? And meta-research, it can be done on, of course, any scientific discipline, but it's really important in medicine where patients rely on reliable evidence to actually use that transparent, reliable evidence in their own healthcare decision-making or their caring decision-making of others. And unfortunately, despite the intention to use the scientific method to implement and get really high quality, transparent results, there's growing evidence. I don't know if others hear that. Okay, thank you. There's growing evidence that there's actually a significant reproducibility crisis, meaning that many studies that get conducted and published either are never replicated at all, or when they are replicated, the results are not the same. We also know that in medicine, up to 85% of the fiscal input or funding towards research ends up being wasted. So that's wasted for a number of reasons. So one of those reasons is that the questions we ask, or maybe they've been asked already, or we regulate or design our studies in ways that have gaps that don't get us sort of the answers we're looking for. Or it can also be in the actual reporting of research. So maybe our research never actually gets publicly reported at all, or if it does get reported, sometimes it's fraught with errors or selectively reported. So there's pieces that are missing. Okay, so it's a meta-research and open science program. We now know that meta-research is the research on research, and some of the imperatives for why we want to do that to make sure we're really sticking to the goals of the scientific method and rigorously. So open science is actually an umbrella term. So a lot of people, when they think of open science, they actually just think of open access. But in fact, open access is one of the many practices within open science. And open science, basically, it's a term reflecting the idea that scientific knowledge and all its outputs, when appropriate, should be openly accessible, transparent, rigorous, reproducible, replicable, accumulative, and inclusive, all of which are considered aspects of the scientific endeavor. So a mouthful again. So open science, I like to think of it as a set of practices and as well as a movement to conduct research more transparently. And as I mentioned, it's not just open access. There are a range of practices. So open data, open materials, open education, open licensing. These are all within that umbrella, as are practices like patient and public engagement, as well as the use of preprints, clinical trial registration or trial registration other study registration as well as the implementation of reporting guideline checklists. So a range of different practices. There's actually no unified definition of open science accepted in the community. So these are just illustrative examples. Others presenting on open science may give different or broader examples of the practices under the umbrella. We know what meta-research is. We know what open science is. So basically, I like to use meta-science to get a bird's eye view of how biomedical research is being conducted and reported. And once I have a sense of that, if I identify gaps, my goal is to create interventions to drive improvements. In terms of approaches, a lot of what I have done has used the 6 methods on the screen. So systematic, especially scoping reviews, I do a lot of. Surveys and qualitative studies. So Jody mentioned that my background is in social psychology. So a lot of my methods training was in these 2 topics. I do a lot of policy audits. I create a lot of training interventions or educational interventions using mixed methods. And actually I'm an expert in actually open science methods. So things like registration, data management planning, and research reporting. So application of, say, a reporting guideline checklist. Okay, so open science and meta-research, there's this idea of bringing transparency to the research process. And it's quite unfortunate that open science and science aren't just one, right? Like that we have to have a whole discipline that seeks to embed transparency means that science as a whole is generally not as transparent as we'd like it to be. I want to share a story with you about patient partner Jenna Kendall, who I've worked with before. And Jenna's story, I think, is quite meaningful to me, and it really emphasizes the moral imperative as researchers to implement open science practices as much as we can and as completely as possible in all that we do. So Jenna, when she was a child, she was a little bit awkward. Some of us lend ourselves more or less towards like athletics and sports, and she was pretty awkward. She'd trip a lot, not particularly athletic, and her parents just thought, she has other skills, like sports aren't really her thing. It happened that Jenna's family doctor had a child Jenna's age, and they were playing together one day, and the doctor saw her at the park and was like, something is not right. I think you need to bring Jenna in. And that sort of discussion actually led to an appointment, and it ended up after some investigation that Jenna was unfortunately diagnosed with muscular dystrophy. And so this was very devastating. She was a young tween, I guess you'd say. And, there's no cures here. It's degenerative. And from that point on, as was suspected with the disease, she started to lose muscle strength. She became reliant on a wheelchair. And one thing that very much frustrated Jenna was that her genetic subtype of MD was never determined. So she never knew sort of what specific type she had. This didn't stop Jenna. She's lived a very full life, and as part of that, she has contributed a lot to her disease community and society. So, for example, she's part of a Facebook community and exchanges a lot in dialogues with other people in her community about their disease and about treatments, as well as sort of lifestyle impact. One day, Jenna was in that Facebook group, and someone who she'd known through the virtual community, an American, shared an article, and it was entitled Limb-Girdle Muscular Dystrophy Mimics an Autoimmune Disorder. And she clicked on it and she read the article and she thought, you know what, this sounds a lot like me. A lot of the symptoms here sound like what I experienced. And she thought to herself, maybe, because I don't have my genetic subtype, maybe I don't actually have MD and I have this autoimmune disorder that this paper is describing. So she took her publication, she printed it out, she took it to her next appointment at the Ottawa Hospital with Dr. Jody Wardman. And she presented it to her and she said, you know, I found this article and it really resonated with me. I think there's something here. And, you know, maybe could it be that I have this because we never found our genetic subtype? And her clinician said, you know what, I don't think that's the case actually, but it's just a blood test. So I'll do the blood test and, you know, I'll expect to see you at your regular scheduled visit. Lo and behold, 48 hours later, Jenna got a call from the clinician indicating that she did have an autoimmune disorder. She did not have MD. And really, the course of her life dramatically changed. So she still uses a wheelchair, but she's regained muscle strength. She describes, for example, how now she can get up from her wheelchair and she could get something from a shelf, which she couldn't do before. So small improvements in her quality of life have been made as a consequence of this. And I think this story it's local, but it's also very powerful from the sense that you can be sure that if it had come to this and Jenna had clicked on the article and it said $25.99, she would not have paid that money. So she would have just sort of skipped that article and carried on with her day. But the fact that that article was publicly available and accessible for her to read and had sort of language that she was able to interpret really empowered her as a patient to take that and really change the course of her life with that. So I like to share this story because I think that we often as researchers in our day-to-day can underestimate the impact of what we're doing on the lives of everyday citizens and patients. And we can get so entrenched within our sort of specific little research circles, whether that's, 30 people here in Canada and 100 people internationally. And it just goes to show that, there are people watching us, there are people, taxpaying dollars going to our work. And I think that we ought to honor and respect the patients and public who support us by trying to be as transparent and openly accessible as possible for them. Unfortunately, the article Jenna found that was openly available, that's not the norm. So just very quickly, when we look at how we're doing with open access publishing, so making our work freely available and free to build upon, what we see is that if you look at articles between 2015 and 2019, so we call these the pre-pandemic years, about 29% were openly available. If you look at articles in 2020 that are not about COVID, 32% approximately are available, as compared to COVID, which 75% of articles approximately are available. So when COVID hit, the whole world came together, science policymakers, and they said, you know what, this is an emerging health crisis. We need to make available information immediately and without delay for others to build upon this. And, so I see this, and I'm an optimistic person, but in this case, we really made this commitment. A lot of people signed it, funders, nations, and so on. 25% is still missing. So it's like, what about that research? And then we see like no real meaningful change in non-COVID literature. So like we are at the Heart Institute, cardiovascular disease is very prevalent. Don't we care to have that research openly available as well? I think that there is this moral imperative. And my point here is to say that using open access as an example, we're falling short on making our work as transparent as possible. Same story for open data. So just a really quick slide here. So a paper examining cardiovascular research publications found that about 97% did not provide open data sets, and about 99% did not provide scripts. So virtually no one is sharing their data in our space. So this is from sort of prestigious cardiovascular journals. And this is changing because of policy mandates and the recognition that, data can be aggregated and synthesized by others and used in new ways to innovate, but also in terms of research integrity and reproducibility, that we have to have this as part of our audit record of our research process in order to maintain and check that. Final example before I jump in and start talking about some of my own research. So this is actually one of the studies that I did with my med student, Mohsen Aliash. So Mohsen looked at clinical trial study registration in Canada between 2009 and 2019. So we took this sort of cross section and we looked at all clinical trials registered with the primary site in Canada. And we found 6,720 trials that met our inclusion criteria. And so with trials, when you're setting out to do a trial, you have to register it in a registry before doing so. So this is from the Declaration of Helsinki. There's very clear national policy and international policy that we have to do this. The idea is that this registry forms a record of what's occurring. So other researchers and even patients can look for studies and see sort of what's going on or what's planned. And when you're done your study, you report your results in the registry, with the idea here being it provides a standardized and publicly accessible view of the results for that study. Ideally, you also go on and publish that work and disseminate it with a broader sort of context. And of course, in most cases, we would expect all of these things to occur. But when Mohsen looked at the literature, he found that only 56% of studies within that 10-year period were prospectively registered. Of those that had reached completion during that time phase, only 39% went back and put their results in the registry. And, a lot of researchers, when I've done audits with organizations, they say, oh, we register our trials, but we never go back and we put the results in because we publish. The results are out there, we published. But we see actually only 55% of registered trials in this country ever go on to be published in any way. And amongst those, many are behind paywalls. When we look at who did all of these things, so registered their trial, reported the results in the registry, and then subsequently published in a peer-reviewed journal, just 3% of trials. So it's basically compliance to this mandate is non-existent. For these examples, so I've provided you a definition of meta-science, a definition of open science, and talked about some of our shortcomings in meeting our mandates for implementing open science policy. So I hope that through those examples, it's clear to you why I need to assemble an army of people to help start addressing open science. So here on the screen, you see some of the current members of the team. So Anna Armand actually starts in November. She'll be a postdoc. Chantal Rip is a PhD student. Ferris and Bassam Al-Mali brothers are research assistants. Mohsen I've mentioned, and as well as Camille Mellet are medical students. And Mark Albert's my current coordinator. And Nana and Stephanie are camera shy, but they are volunteers, undergraduate volunteers in the group. So please, if you see them around, do welcome them. We're all sort of just starting this fall. The group, I was actually asked today to mention sort of relevance of EDI in the program that I'm building. So I'll do that a little bit in the session, but I wanted to explicitly mention that I actually have created a lab code of conduct, which I consider a bit of a living document for the group as I'm starting up this program. So you can check it out. It's openly available there. It has everything from sort of goals and remits of our program to expectations, both for myself as a PI and staff and trainees. It has an EDI statement, it has an Indigenous statement as well. So it's I think not perfect, and it will evolve as new members and themes come across our plate, but it's a starting point. So you can definitely check it out if you're keen. I'd welcome feedback as well. The rest of the session, I basically want to give you an example of 3 illustrative research themes that I'm working on right now, and then open it up for discussion. So the first is implementing and monitoring open science. So the good news for me, as someone who's just launched a research program in meta-research and open science, is that despite the fact that open science is not very firmly embedded within our research ecosystem, it does appear that open science is here to stay. So there's a lot of science policy mandates. Canada has a national action plan on open government. We also have a directive on open government. We have Canada's roadmap to open government. And the tri-agencies, including CIHR, who fund many of us, have a number of open science policies, both historic and new, including open access, clinical trial registration, and incoming data deposit requirement. In the broader international landscape, it's very similar. So we have some pan-national recommendations, such as the UNESCO recommendations for open science. We've got G7 working group on open science I've contributed to. Also EOS, the European Open Science Cloud, a lot of money been put towards that. And the Office of Science, Technology, and Policy in the States also have produced a lot of policy mandates around open science. So what I'm looking to do in this first program of research is actually to create an institutional open science dashboard that monitors open science practices at the researcher level in aggregate. So what I set out to do, this was work funded by the Wellcome Trust, is to bring the international community together and to agree on a core set of open science practices that we ought to monitor for biomedical institutions. And once we had that, the goal would then be to take those core open science practices and to create an automatic digital dashboard that could take an institution's output and spit out information about how we're doing or performing on those practices. So the first thing we needed to do was to establish the community needs for the dashboard. So to do that, we brought together 80 participants from 20 research performing institutions across 13 countries. So it was very international in scope. We did a Delphi with 3 rounds, so two rounds of surveying and then a consensus meeting followed by voting again. And this work was published at the start of this year in PLOS Biology. And ultimately, it led to a set of 19 core open science practices that institutions said, like, we want to monitor these things. Our participants were primarily institutional leadership and administration, though there were also like open science experts and librarians present as well as patient partners. We have this sort of prioritization of items as well. So we looped them into 2 groups. So traditional open science practices and then some broader transparency practices that aren't typically considered within that umbrella of open science, but that folks thought were critical. So what we've since done when we had that community input is, I say we, but it was most certainly not me. The programmers on our team went away with those practices in mind and implemented them into a dashboard. So you see here a screenshot of our dashboard. This is mocked up using the Montreal Neurological Institute, who's our partner, in terms of their colors and branding. And what you can see is here on the left, there's the sort of overview page, which is what you're seeing part of. And then you can drill down on the left further and get information on specific open science practices. So here you can see the Neuro had identified 3,606 publication outputs. 342 of those had open data. So you can see the trends across time. And you can also, for instance, we can display it as count data as well. So for each of the open science practices that folks agreed upon, we've done our best to fully automate that into our tool. So we have all the sort of big hitters, so open data, open code, open access, use of ORCIDs, clinical trial registration, and so on. So we now have this tool, which I think is quite high quality. And our next step is we're actually implementing it within partner sites. So the Montreal Neurological Institute was our first partner, but we're looking to implement within broader networks. So the first network that we're considering is the EUHA, which is the European Union Hospital Alliance. They were actually sort of our initial partner in getting funding. So the idea is that this could be across the European Union Hospital Alliance institutions, something that they all adopt and we implement for them. And what's really cool is it provides a means for cross-sectional comparison both within an institution as well as between institutions. So, you know, we can see how we're doing this year compared to next year, but we can also see how we're doing compared to our competing institution or an aggregate of competing institutions as well. With the idea being that this tool will not only be helpful for institutions to track how they're doing, but this sort of core outcome we can track as a broader biomedical community how we're doing. Steps, we're doing a number of different things. So one thing is that this institutional biomedical dashboard relies on institutions identifying their publication output. So they essentially give us a list of DOIs, we feed them into our tool, and then we spit out all the open science practices. So we're conducting interviews with our 20 partner sites across the world right now to better understand how they track their publication output. So the Heart Institute, we're doing really well. We've got Sarah Vicentini. She keeps a wonderful record of everything that we're doing from year to year. Not all institutions have this. So we're working with them to create an implementation handbook in terms of how they would aggregate that information and then implement it within our tool. So the idea is that we could offer a hosted dashboard for these institutions, or they could actually take our handbook, take our open source tool, and run with it. And the idea is that over time, within these networks of communities of practice that we're building, we intend to actually bring them together and conduct step-wedge trials using mixed method educational interventions to drive improvements in the open science practices. The theme I'm going to move on to, just giving you sort of a quick overview of a couple themes here. This one is pertaining to data management and planning. So this research interest in data management and planning really stemmed from the Canadian Tri-Agency's Research Data Management Policy, which came out a couple of years ago. If you're not familiar with this, you're going to become more familiar because it's being implemented in phased approaches, and it's going to be hitting researchers pretty hard pretty soon. So the first thing that this policy did is it basically said that, you know, as a research community, we haven't been managing our data perhaps as robustly or as overtly responsibly as we'd like to. And they're sort of addressing that. And they're addressing that in three ways. So the first is that they required institutions in receipt of tri-agency funding to develop an institutional RDM strategy. So that really explains sort of how they're dealing with RDM internally. So issues of privacy, research consent, data management, data sharing, and many other factors. So I would say all institutions have probably had some policy or some educational outreach in terms of data previously, but this mandate really formalized that. And these required that they be publicly posted and reported to the tri-agency. The second thing this policy required is that it's being phased in, but it'll hit us in the spring CHR competition, is data management plans and grants. So never before had we ever been required to do that. And now they're phasing them in, and that phasing is getting a lot faster, wherein we're going to have to actually do this when we're applying for funding, and that will eventually be considered as part of our application. And the third point of this policy is data deposits. So the idea here is that if you're funded by the tri-agencies, at a certain point, the mandate will be that unless there's some reasonable explanation, all funded research will have to be deposited. That doesn't mean it's publicly available. It's not a requirement for open data. It can be available through sort of restricted access, or there may be very exceptional circumstances where the data can't be shared at all. But generally speaking, this data deposit is coming, and it's going to impact all of us. So when I read this policy a couple of years ago, you know, I thought, oh, this is great in theory, but looking at my own research, looking at my peers and collaborations I've been part of, I thought this is a big step from what we're doing now to what they're saying they want. So this data deposit requirement, they haven't given us a date, but I've heard that they're looking towards January 2025. So study is funded after that date would be subject to that. Like that's like the blink of the eye. So one thing that I wanted to do was basically to create a program to sort of look at the meta research, meta science, and education that's happening as a consequence of this policy. So I've got a little bit of directed funding from SSHRC to actually start off by actually auditing the institutional strategies that different institutions across our country had to come up with. So I'm looking at things like, is there sufficient expertise within an institution to support RDM? Is there sufficient infrastructure? And is there sufficient funding? So generally speaking, these strategies, when looking at them, they're a little bit whiny. So the institutions basically feel very frustrated, I think, by this mandate. And I'm trying to sort of document that and document what's planned, because what I'd like to prevent is duplication of unnecessary effort on different tasks that we could be doing as a community. What is interesting about this mandate was that there was actually no clear sort of standards that the strategy had to have. It was very broad. And now the tri-agencies want to look at sort of what institutions have come up with. So you can imagine without a clear mandate of what needs to go into it, it's like a whole lot of variance in my sample in terms of trying to capture what's going on. But I hope to report on that with a view that we'll have some sort of synthesis of these strategies and then can actually make a plan to go from what they have planned to what the tri-agencies is going to require of them. Bit that was part of the mandate was the data management plans and grants, and eventually this requirement for data deposits. So as part of some work funded by the Alliance, or the Digital Research Alliance of Canada, as well as Compute Ontario, I'm working to address these sort of components of the strategy by creating a biomedical data champions program in Canada. So you can actually check out our data management resources on our Data Champions program website. So we have a website of resources that we're adding to regularly. We also conducted a 14 lecture speaker series while I was on mat leave. So these are very specific to biomedicine, which is something that for me, I was very salient of in conducting research and audits in this space. Like the nuances within medicine are so varied. Like people come to me and ask me for support with data management. Well, if you're looking to create a data management plan for a trial versus a systematic review versus like a preclinical study, the processes are very different. And even if we just like delve into preclinical, what if you're doing like proteomics studies versus genomics versus cell lines? Like there's a lot of variance here. And I don't think our community is presently ready to adhere to these mandates. So we're trying to bring together folks with expertise and pass those on in a way that's structured to the community. So one thing that I've also done is I've applied for a planning and dissemination grant in the summer, looking to bring together faculties of medicine in Canada to create concerted education programs so that we can all be part of the same discussion and be creating the same standards for our community. The last illustrative research theme that I wanted to mention is patient engagement in cardiology. Engagement is, it's becoming more topical. A lot of funders are asking for this. It's the active engagement of patients in the governance, priority setting, developing the research question, and even in performing certain parts of research. So for me, I've been interested in patient engagement and working in this space for about 5 years. So I've actually been doing meta research on patient engagement. I kind of have the sense as like a researcher, my own experience is that I kind of got the moral imperative of why we would want to engage patients. And I was able to, with my institution's support, find patients. And then it was like, okay, now I have my patients and I want to do patient engagement. What do I do? And I didn't really know how to structure communication with the patient. I wasn't sure sort of what parts made sense to involve them. And I just found from my own perspective that it was a lot of learning on the job. And I think that many of you may feel like that as well. So one of the things that I'm looking to do is to bring my experiences as well as my meta research lens to patient engagement and try to come up with supports to identify sort of barriers and facilitators of patient engagement, and then create training to support the community. So here you can see some examples of some of the work I've done on patient engagement in the past. So I just wanted to speak a little bit about them. So in this paper, we looked at editors-in-chiefs of biomedical journals' perceptions of patients as co-authors on manuscripts. And this was based on my work actually consulting, where people would come to me and say, like, what do I do? The editor-in-chief won't let the patient be an author on the paper. And we have the ICMJ criteria for authorship, which is sort of sets out who qualifies for authorship on a manuscript. And it doesn't really consider patient contributions appropriately. So they were saying, a patient doesn't meet ICMJE, they can't be an author. And what we found was that most actually editors-in-chief understand that patients are sort of a different case scenario and that they shouldn't have to meet this criteria. So 78% approximately agreed. There's still 30% that said that they don't think it's appropriate for patients to be authors. So I think that this type of information is important as researchers on the ground trying to engage in patient engagement. We're going to encounter roadblocks like these types of editors in our pursuit to publish. So documenting that and creating education tools for the editor community, I think, is important. Another study that I have there at the bottom is identifying potential barriers and solutions to patient partner compensation or payment in research. So we know, for example, that many patient partners that contribute to research do so in the capacity as a volunteer, which is great and certainly one acceptable option for their contributions. However, we also know that I can say from my experience, but there's documented research on this, is like in my personal experience, a lot of the patient partners I've engaged have been upper middle class white women. And of course, this is not the general public's demography. So we need to find ways to actually attract broader people to share their views with us. We talk, for example, about the need for precision medicine and getting patient perspectives on that. Well, it's hard to do if you have this sort of very homogenous representation of the public through that type of patient partner. And one of the solutions is, I think, payment. To actually compensate people for their time that they're contributing to be a patient partner. And this piece looks at sort of barriers and solutions for that. And then finally, the last piece here, a piece I worked on with Peter, which was a call to embrace a culture of openness in cardiovascular research more broadly. So patient engagement, citizen engagement, as well as open science more broadly were sort of brought to the fore in that. So with these sort of previous experiences, I got a little bit of funding from the Oracle sort of Precision Medicine Foundation to conduct a study actually to understand barriers and facilitators to engaging patients in cardiovascular research. So this point, you should all be taking out your phone because we're doing a survey as well as focus groups looking at barriers to patient engagement for anyone in research. So if you've ever done cardiovascular research, whether you're a researcher, a trainee, research support staff, or a patient partner, this is a survey that would be appropriate for you. And we're going to follow it up with focus groups to sort of look at people's experiences within Canada, within cardiovascular research, and seeing sort of what supports that they're using already that are working well, and where there are gaps and where more supports might be needed for those different stakeholders that I've mentioned to better implement patient engagement. And also part of this is capturing sort of what we think the value of open science is for our community. Coming to the end here, lots of time for discussion and chat, but I hope today I've provided you with an overview of what meta-research and open science are. I've talked about how we're falling short on open science. So open science is unfortunately not the same as science yet. So there's a need for a sort of focus on bringing transparency to the day-to-day research process because it's not always there in the level we'd like it to be. I've talked about how many outputs of science are never ever shared, and how outputs that are shared are often done so in biased ways. And I've talked about the moral imperative to patients and to taxpayers to make sure that we're actually upholding open science more completely. The reality is that if we're going to move towards open science, it's going to require a lot of behavior change. So the status quo is not going to work. So if you're going to implement open science, you'll have to join me on that upper path hiking because it will not be sort of, I think, a linear path. It will be a path of resistance. And what we need to consider is what supports we need as a community and how to get those to better implement and actually achieve open science and the transparency and rigor that we're all looking for, but perhaps haven't actually been trained in or formally educated in. So we can be well-intended, but fall short of meeting some of these mandates because maybe we're not aware they exist. And when we are aware they exist, we may not just actually have the skills to know what to do. So I think there's a clear need for continuing education in this respect. Up there, definitely it's time for questions or comments if anyone has any. Thank you.
Thank you so much. Okay, can you guys hear me? Okay, all right, thank you so much. So that was a wonderful introduction to your program and to, like you say, the kind of what's coming in the future for all of us in terms of being able to integrate this into our research. So we're going to open it out now to discussion and questions both within the audience here and please online, if you have any questions, you can enter them through the Q&A and we can read them out here. So I'll open it out now to the audience. I see Peter coming, tracking his way over here. Come on over, Peter. Yeah, please. Yeah.
So much, Kelly. I think we're so fortunate to have you at the Heart Institute. So just thank you for being able to join us. To lead this really global effort out of our institute. And these things in terms of culture change does take time. For example, for a long time, clinical trials were not, mandated, to develop evidence, right? And I think those took a while, and now it's really actually the given. And I think, even calculating sample size, so it took a long time to get people into, their grant applications. And so I think this will definitely be something that will take time, but it's super important. Just a little bit of I guess the gap of the willingness versus, the pathway to get there, even from the policy or tri-agency point of view, right? So no question, I think the policies are good, the guidance are important, but there is actually a lot of requirements, in between to actually get this to happen, all the way from, institutions, not quite sure exactly, where to deposit the data.
Yeah.
And so how do we actually get the research community to actually agree on, what to do? And the real daunting challenge is that and the people make fun on Twitter or X, the fact that when we publish our paper, like in Nature Family, right, it requires 7,000 pounds.
Yeah.
Right, just to have open access, right? And where is that funding going to come from? And that's just one little piece, right? Of this whole, I think, chain. 7,000 pounds. That's how much I have to find money. 7,000 pounds. Yeah. Otherwise, no open access. Yeah. So, and it people make fun of it, right? So you spend all this time doing research, and how come you have to pay the journal?
Yeah.
Yeah. So the so what is so how do you see, because eventually these things will need to evolve?
No, thanks, Peter. That's really a series of great comments and questions. So I think with respect to the science policy landscape around open science in Canada, I think it's like a great illustration of failed implementation. So we have great policies, and now they've added another one on data management, right? So, adding policies without monitoring is obviously not effective. We've seen the Metaresearch, the study I showed from Mohsen Eliash, like we're not getting there even with registration, which was like decade old, right? So I think it's highly problematic that they're adding additional mandate without additional support. So from my perspective, some things that I think that would be helpful to the community would be dedicated funding from the tri-agencies to conduct meta-research and to create educational tools. So it's like virtually impossible in this country to get funding to create educational tools from the tri-agencies. I have to get all my funding from Europe because they're sort of much further ahead in this space. The other thing is, which again is failed implementation, with the data management, you can actually request funds towards supporting data management in your grant. Great. However, the pot has not grown, right? So we still have the same amount of money so that actually makes us less competitive internationally, less innovative, quite problematic. So I think what they need to start doing is creating policy that has supports for it, but I don't think they're actually capable of creating the support. So I used to think that, they need to give us support and help us. I think what they need to do now is give us money for us to build it up and create it ourselves, because the nuances for data management, just as I mentioned within medicine, are so specific that we really need this to be like a grassroots thing, that it comes from the bottom in order to meet those mandates. The second part about monitoring, for example, with the trials, they last year in 2022 came up with a really firm statement on Twitter or X, and they were saying, now we're really monitoring this. This is really problematic. We're really going to do this. So I was like, retweet, happy, great news. They're really going to monitor it now. Wonderful. Then I see what they did. So for folks who got funded for a trial in the year previously, they sent them a survey and they asked them, did you register your trial? And of course, the response rate is 53% or something like this. It's very poor. And you can imagine the selection bias, right? So this is not how we audit and monitor compliance with a policy. Go to the registry, look who's done it, look who hasn't, and it should be a condition of funding release or certainly the reporting at the end, right? So I think that we're falling short on our implementation because there's no monitoring, and that I think is possibly going to be true for data management and sharing, which will lead to us having this very long, drawn-out process in terms of actually getting from where we are to where we need to be, which makes us less competitive because other stakeholders like journals are asking for these things. With respect to your very large sum of money that you paid for your publication. It's true, it's very typical. We're actually, tomorrow at the university, we're hosting, it's open access week, and there's a session between 1 and 3 that I'm speaking at on open access and commercialization. So it will address exactly this issue. So I think as a community, we have to sort of reevaluate kind of like the DORA impetus. So incentives and rewards for publishing, why we care so much about certain impact factor scores and things like this, and whether there are alternative methods that we can throw the sort of commercial method of publishing on its head and still, create good science and still move up and evaluate and have a system in place for judging researchers from one to the next. I'll stop there.
Comments that we're really lucky to have you to help us get on the right track with all of this. And the comments remind me, Peter's paying for that $7,000, 7,000 pounds.
Yeah.
Pounds.
Yeah.
The Glocken, I don't know if you've seen the Glocken tweet little video clip where he's basically saying he has to pay for the research, and all he gets at the end is prestige, and the journals are making all kinds of money, et cetera, et cetera. Anyways, sidebar. Please look it up. It's hysterical. So one of the things is you talked about funding, and I'm still kind of grappling with this because we do want our funding organizations and our institutions to fund science. I think open science in principle is where we should always be heading. We also have increased regulatory burdens, which we know about. Those cost money. This is now adding costs and money. And I just don't know where all of this money is going to be coming from to help support it and still be able to do innovative research. So somewhere along the line, we have to find a balance. I see Carrie Ann is kind of asking something similar to know where we can go, how we can actually do this, and without kind of overburdening the costs and also disincentivizing research. That's one of the things that really concerns me.
Yeah, I think it's a great point. Obviously we work in a landscape where resources are finite, and we're being asked to do more with less is what's happening in our ecosystem. So I think given those constraints, what I think we need to do is collaborate and develop consortiums. So I'm looking to bring together faculties of medicine in Canada so that we can, with the least amount of dollars, produce something that serves our entire community. Like why, for instance, does our institution have to create something? McGill has to create something. U of T, Alberta, et cetera, right? We're all serving basically the same community. And I think we need to come together as a community in biomedicine and others on their own and develop solutions that work for our communities. And the quicker we can mobilize and train the next generation, the better this is in terms of dragging on the implementation, right? Something like open access, the barrier to open access is the fee, as Peter mentioned. There's not like a huge learning curve that comes with publishing open access. It's not the same with data, right? Data, there's an enormous learning curve, and in this country, a significant lack of expertise in terms of actually doing this. So it's not even a case of making time and space and giving money. Like we just don't know how to do it. I think we need more expertise in this country. We need more training, and I think what I would suggest is some sort of like standardized training courses that we put our researchers through as they go through training, so that we sort of address this as in a cohort with our trainees, building those skills from the ground up. There are people at the ends of their careers who I don't think are necessarily going to learn all these skills. We need to support them in improving, but acknowledging that this is not going to happen overnight, even if this mandate comes in January of 2025.
Thank you. Okay, lots of good discussion. I just want to go to the online questions for one moment, and then we have a couple more here in the audience. So Adam says on the first one, how can open science practices be leveraged to fuel open innovation? And as a follow-up, Carrie-Anne Mullen asks, given how quickly this field seems to be moving, it occurs to me there's a number of opportunities to develop, as you just said, innovative templates and tools and registries, applications, including potential commercialization opportunities. So who in Canada is sort of innovating on this? A Center for Open Science, any opportunities for us to lead any of these tools and innovations?
First one, so the open science practices leverage to fuel innovation. This is really interesting. So I share the example of the Neuro. So at the Neuro, they actually did a evaluation of all patents that had been filed for 3 decades. And they found that, people, when they create something, they go and patent it to make sure that it's like protected and it's theirs. What they found is that they actually never really got any money off any of those patents for 3 decades. So they've moved away from that model altogether. What they get money from is actually people, charitable donations. So people making like private donations based on their spin-offs. So I think that there is this tension between open science and open innovation. You don't have to be completely shut or completely open. I think that there's a sort of middle ground that you can navigate as well. In terms of open science supporting innovation, I think one thing people should not underestimate is how their data can be used by other people. So I often hear researchers say, well, why am I sharing my data? I've already done everything in my data set. There's nothing else there. But actually people can aggregate that and innovate in ways that you as an individual scientist might not have that particular perspective or training. So I'll stop there with that. With respect to Carrie-Anne, her question, I think that, so our Data Champions program looks to do exactly that. So we have, for instance, 3 templates for different types of biomedical design. So right now, when you're doing a DMP in Canada, the tool is the Portage DMP Assistant. But when you actually practically go in there and, maybe you have to create this for your grant or for your project, you're trying to create a DMP. When you look at the templates that are available, they're just not fit for purpose for our community at all. Like, so for instance, it's like generic open workflow or biomedical workflow. Like we can't all use the same template. Like that doesn't make sense for the variance in the community studies. So we've started off by creating one for trials, one for preclinical animal studies, and one for systematic reviews. So we're going to add to those, but the idea is that the community will be able to use these for what they need in sort of a purpose-built way. And we'll be adding additional training. Within Canada more broadly, there's not a lot of expertise, as I said. So there are some people working in this space. The library at McMaster seems to be quite forward-thinking, McGill as well. But I think we've got a ways to go, Carrie-Anne, in terms of getting these templates out there. We can look to other jurisdictions as well. But again, they tend to be very generic and not very specific. So we're taking this step with the global community, and we're not too many steps behind. I think that they're not so much more ahead in this respect.
Cost to be had. If you think of copy editing, editors and chiefs, servers, there are costs that are part and parcel of the publishing process. But I wonder if there's more reasonable costs. If you think of the NHL years ago, there was a cap placed on salaries, right? It was a major change in how we fund and deliver on sport in Canada and internationally. But whether there's something like that within country that might be reasonable, so it leaves more funding perhaps, in the tank for research, plus the open science aspect. So that's my comment, just to, as I think about your presentation, reflect on the available funding. My question is regarding actually one of the other many areas of expertise that you have is measuring research impact. And I've sent you some emails on this in considering how we evaluate, the impact of our scientists and our programs, and wondering if you could maybe just speak to what some of those other alternative metrics might be as we consider how to evaluate our own programs within the Institute.
Yeah, for sure. So I think first, with respect to your comment, I like the idea, and some that's already being implemented in some places. So for instance, even the Heart and Stroke, they'll only give you $3,000, right? So that's what they've said is their salary cap for OA publishing. In the European Union, they're similar. I think I'm like quite, when I look at the current publishing system, I just think it's very not sustainable. I also don't have a lot of faith in the peer review system as a sort of quality vetting process. If you think about peer review, you know, well, peer reviewers aren't paid. Most editors aren't paid. Those are the people bringing the skilled expertise. And not only are they not paid, they're not trained. So, you know, people may say, like, I feel peer review has improved my paper, but there's actually very little evidence for peer review doing so. And when you look at preprints and compare them to their published version, they're not very different. So it's not clear, like, what that process has brought. It's probably that also people who create preprints have higher quality work maybe than people who don't. But I think generally, I think the system needs to be thrown on its head. The cost, there are costs for like indexing, archiving, perpetuum, and so on. But in our modern digital world, I don't think it's £7,000 for Peter's article. So I think there's a huge commercial aspect that has been linked to prestige and research assessment. So we need to sort of decouple those and find new solutions. With respect to your second question, or your actual question about research assessment, I think that different communities will need different solutions. So what works in one community may not work for another. Within biomedicine, my sense is that I presented this sort of open science dashboard that institutions can use to track compliance to different policies. But that could also be used at an individual level to look at how individual researchers are performing. So rather than saying, okay, you know, Jennifer has X number of publications, we could say, okay, well, what proportion of her publications engaged a patient? What proportion of her publications were transparent, had data availability statements, and complied? I'm not saying that's how we begin in totally evaluating people. That would be, I think, not acceptable, but that may be part of how we start to think about research. So thinking it more broadly than just quantity of publications and whether they're in Nature or not. We can think, you know, not just about those things. Maybe we do them in tandem for a while, but I think the sort of incoming mandates need to be considered. We can't be asked to do more and that not be part of how we're evaluated, right? So right now, like, we're in a position where most people don't know how to create a data management plan. Most people don't know how to implement a data management plan. So maybe there's like a transitionary phase where our time spent becoming educated and performing these tasks should actually be honored and recognized in some way in terms of how we're being assessed. I think that would actually move us forward more quickly.
About patient engagement. And you touched on this, but one of the issues I have is the patients that are being engaged now, like you kind of alluded to, are not really representative of patients as a whole. I have to say that when patients, even the ones that we are getting engaged, they're bringing new perspectives, which is obviously a start. But how do we get to the underserviced populations, vulnerable populations that aren't necessarily being represented?
Yeah, I think it's a really great question. And I know from my own engagement, which has generally not been with those communication or with those populations, I've sensed that we actually need training and supports for the patient partners. So even the patient partners I've worked with who are typically very educated, you know, they join a group meeting and we're talking about publishing and we're talking about registering our trial and we're talking about, you know, this, that, and the other thing. And, you know, they're educated people, but they're not scientists. So they need some support to be sort of onboarded and supported to have basic information about the research process, the research life cycle, to actually make a meaningful contribution. So I think that is needed currently. And if we're going to extend more broadly, it'll be desperately needed to have that information there and at the right level to actually make people feel confident and comfortable in what we're doing. I know from my own experience, I had a situation with engaging a patient where basically we submitted a paper and it got rejected. And I saw it in my email and it got rejected. I had some other things to do, carried on for a few hours. And I went back to my email and he was devastated. My patient partner was really, really upset that, you know, our work had been rejected. And, you know, it was just like absolutely no sweat off my back because that's just part of the research process, right? But then it made me realize that, you know, we need to spend more time actually for them to feel safe and comfortable. They need to have these basic sort of training skills and just what science is and what we're doing and then how we can leverage them and support them. I also think, especially when working with typically underrepresented communities. We need to create safer spaces for them to come and dialogue. I know in some of the meta research on patient engagement, patients have told me, you know, I've been paid to come to a conference and share my story, and I, you know, pour my heart out at the podium for 15 minutes, and then I take my seat and everyone's like, oh, thank you. And there's, you know, they're saying how they need some supports to be able to do that, and those aren't really offered to them. And I think that that's something, like, we're putting them in vulnerable situations without really the netting to support them. Yeah.
Thank you. All right, we are at the hour. So this has been a really fruitful discussion. And I think it's pretty clear that this is really just going to be the first of many, many discussions in this field as we all work to kind of integrate these practices. So thank you, Dr. Cobey. And I think you might be available for a couple of minutes if anyone else has any questions. And thanks to everyone online.
Thank you so much, guys, for your time, and I'm very happy to connect either now or via email. Thank you.